V4, V5, V6 is just sort of around here. So V1, V2, V3, V4 is like anterior septal. V5, V6 is around the lateral. So bradyarrhythmias. So you can sort of think of it as SA node origin or AV node origin. So AV node or SA node. So if it's SA node, it's just like an inherent bradycardia. So it could be a sinus bradycardia, like elite athletes who have bradycardia, or it could just be like a vagal. Sorry. So it could just be a vagal input. So parasympathetic activation. If it's an AV node problem, you'll be thinking AV node heart blocks. So first degree heart block, second degree, third degree. So for heart block, it's not enough electrical conduction getting to getting through the AV node. So there are, you guys probably know all the different types. Yeah, I don't know why faculty has given us ECG and cardio exam 4 years in a row for some reason for OSCE. So hopefully they won't give it to you guys. But we had an AV block in our first year OSCEs. So first degree AV block is just a prolonged PR. So as we talked about before, it's more than 5 small blocks. So as you can see here, it's like 9 to 10 small blocks. And it's just a constant PR, I guess, interval, prolonged PR interval. For second degree type 1, it's Wenke back. So it's prolonged, as you can see here, and then it gets longer, and then it skips it. So there's no QRS. So pretty much it was unsuccessful in getting the electrical conduction across, which is why it skips the ventricular depolarization. For second degree type 2, it's more just randomly skipping it. So as you can see, you've got the QRS, and it's just suddenly gone, but it's not actually increasing in length. These two are actually more dangerous compared to these two. So the third degree is just sort of separate things. So they're sort of just not in sync at all. So the ventricle is doing its own rhythm and the atria is doing its own rhythm. So here's the atrium, and the ventricle. Oh, sorry, that's the wrong one. The ventricle. Atrium. And yeah, so for management, you give atropine because that increases your sympathetics, so increase your heart rate, all those sorts of things. And because second degree type 2 and third degree are more severe, they might actually need a pacemaker. So for tachyarrhythmias, so it can either be narrow or broad. So if it's narrow, you think of it as supraventricular, so it's above the ventricle, so AV node, sinus, like atrium, so everything above the ventricle. If it's like really broad, like a thick QRS, it's generally a ventricular cause. So that's a really good way of just quickly screening the ECG for like a spot diagnosis. So if it's an atrial origin, it can just be sinus tachycardia, or the atrial cause, so atrial tachycardia, atrial fibrillation, atrial flutter. If it's AV node origin, it can be AV re-entry tachycardia, AV node re-entry tachycardia. So these are kind of just, I don't know, it's just buzzwords. So it's generally like a young girl who's come in, who's got like fluttering of the heart or something like that, and it's probably AV node re-entry tachycardia, just because of the age group. And then broad spectrum, you've got VT and ventricular fibrillation. So these are the dangerous ones you want to look out for. These are the only 2 rhythms that are shockable, so that's also good to know. Atrial fibrillation, so please learn this really, really well. They love atrial fibrillation. So it's when the left atrium it's sort of fibrillating, it's not contracting properly. Yeah, it's generally caused by mitral regurg or left atrial dilatation, as well as hypothyroidism. So that's why you also do the TFTs to screen for hypothyroidism. Symptoms, mainly palpitations, tachycardia. CHA2DS2-VASc score, so know this really well. So what does it stand for? So congestive heart failure, high blood pressure, age greater than 75 is 2 points. Diabetes, past history, oh no, sorry, that's meant to be, wait, what is that? I don't think it's meant to be that there, sorry. And then V is vascular or stroke, and then another A is for age, between 65 and 74, and then sex category is for S, if you're female. So the buzzwords on ECG, so as you can see here, so I think someone taught me to get a piece of paper and then I guess put it on the, put it on the ECG and then draw a line like for each of the QRSs, for like the first 4 or 5 QRSs, and then move it along to see if it's regular. So if it's not matching, then it's probably AFib and it's irregularly irregular. There's also no P waves that you can see here. It's just all fibrillating, so it's up and down. And obviously you've got the narrow QRS because it's supraventricular. Yeah, management, you have to know this really well. So SNAP-W, educate the patient. So for pharmacological, they can test this for OSCEs or for written. So last year we had a question which was, oh sorry, not last year, yeah, just, you know, a random question. So if the guy has, so yeah, the question was like, they sort of gave us the ECG and then they were like, this guy's got asthma, or I think, yeah, asthma, and then they wanted to know what was the best rate controlling drug. So the options were beta blockers, digoxin, they had some of the rhythm controlling, they also had cardioversion as well. So, so first you had to interpret the ECG, figure out it was AFib, and then you had to figure out rate controlling is only beta blocker, calcium, and digoxin, and you had to rule out all the other ones. And then because you had the asthma, you rule out the beta blocker, so the answer is actually digoxin, which is not actually used that often for AFib, but that was just the question they had. For rhythm control, you've got all the things that affect the electrolytes. So amiodarone, fleconides, sotalol. Fleconides usually just for young people, so it's generally started with amiodarone. For anticoagulant treatment, they've actually changed the guidelines, so this is not actually entirely accurate in practice. So I don't know what Monash wants from you, but there used to be if CHA2DS2-VASc was 0, you can give them nothing or aspirin. If it's 1, you give warfarin or aspirin. If it's 2, you give warfarin or NOAC. But nowadays, because NOACs are so good and they're sort of used everywhere now, they've changed it so that if it's 0, you don't give anything. They found that aspirin is pretty useless. And then if it's 1 or 2, you consider giving them NOACs. Yeah, and then if they're hemodynamically unstable, do the electrical cardioversion because that can sort of make it recover quite quickly. If it's over 48 hours and the guy wants to do electrical cardioversion, you have to make sure to give them anticoagulants for 3 weeks before and 4 weeks afterwards, just because the risk of atrial fibrillation is so high for giving them stroke. And if none of that works, surgical ablation. So this is a nice summary of the treatment. Yeah, it's not too accurate anymore, sorry. So paroxysmal SVT. Yeah, none of this is too important. Mainly the young females drinking alcohol, coffee, or stressed. Treatment, vagal maneuver, so carotid sinus massage just here. Get them to do the Valsalva maneuver, and then you can give them adenosine as well in the short term. Yeah, so this is really important. So as you can see, the QRS is really fat. So this is way more than 3 of the small squares. And it's pretty regular. And as you can see, it's like 150 beats per minute. So it's quite fast. So I guess the buzzwords are wide QRS, tachycardia. And what you need to know is the management. So if it's like an emergency and it's in the acute setting, obviously do doctor's ABC. Put on the monitors, the cardiac monitors to see the rhythm. And if they're hemodynamically compromised, give them a shock, so defibrillator. And if they're not compromised, you can give them the amiodarone. And in a chronic setting, to prevent VTACs, you can give them beta blockers as well, just because it helps reduce the heart rate, things like that. Torsades, it's just a buzzword really, and a spot diagnosis. So as you can see, it's like all over the place, sort of up and down. It's basically this, but it's up and down everywhere. It varies in amplitude. Buzzword is magnesium sulfate. Yes, VFib. Yeah, we had an Auscultation on this last year, and one of the questions, it was like a 3-minute question, I don't know why. It was like, what are the reversible causes of, I don't know what they said, it was cardiac arrest. And I actually didn't realize the 4 H's and 4 T's were the reversible causes. But yeah, these are the reversible causes. So like hypotension, hypothermia, hypoxia, so all the vital signs, and then electrolyte imbalances, so hypokalemia. And then the 4 T's, you've got tension, pneumothorax, tamponade, toxins, thromboembolism. So all of the sort of cardiac emergencies, cardiac and respiratory emergencies. So as you can see, VFib, it's like sort of just really like fibrillating. Yeah, pretty screwed. So doctors ABC, defibrillation as soon as possible. And then if it's a pulseless electrical activity, so that's not VFib. So that's when it's just pulseless and it's sort of flatline. It's actually not shockable, so you can't really do much about it. Yeah, so this is just a summary of all the buzzwords of third year. So read it in your own time. Hopefully it'll be useful. Okay, so yeah, EMQs and spot diagnosis. So just in the interest of time, I'll quickly go through them. So 60-year-old with history of stable angina, worse with exertion. And then he noticed a crushing chest pain, did not respond to GTNs. So that's pretty bad. So it means it's no longer stable angina. There's also ST depression, so it's probably an NSTEMI. Troponins are still pending, so it's probably NSTEMI. So we rule out the STEMI here, so it's most likely acute coronary syndrome, which is an umbrella term for NSTEMI, unstable angina and STEMI. Patient with ongoing chest pain. Symptoms, yep, and then he's got adequate anticoagulation, he's got treatment with aspirin, and he has a past history of asthma. So in this situation, because it's got adequate anticoagulation and aspirin, you don't need to give those anymore. Although arguably you could give clopidogrel, but I don't think that's what they're getting at. I think most likely because they've included asthma, they want you to think about beta blockers because it's got the ACS. But because metoprolol in Monash is contraindicated with asthma, the next line would be calcium channel blocker, so amlodipine. A lot of people thought it was clopidogrel, but I personally think faculty answer was amlodipine, but we'll never know. Next question, so 60-year-old guy, it's got chest pain, elevated JVP, hypotension, clear lung auscultation. So the main thing you want to know is the ST elevation in leads 2 and 3. So as we talked about before, lead 1 is to the left, lead 2 and 3 are down. So most likely inferior infarct. Evelyn, 65-year-old, ischemic heart disease, worsening shortness of breath, unable to get to the letterbox, blah, blah, blah. So she's got a lot of signs of sort of fluid accumulation in the lungs as well as in the peripheries. So the JVP is increased crepitation to the lungs, so fluid overload in the lungs, as well as a dilated heart that's fluid overloaded. So they've definitely got heart failure. So she's already on ACE inhibitor, she's already on furosemide and beta blocker. So from our BLADE mnemonic, the only thing left is spironolactone as, I guess, the next step of management. So that's the answer. So I'm going through this really quickly. This is just, I guess, spot diagnosis. So it doesn't look like, you know, pneumonia. It's more throughout, more fuzzy. So it's an APO, so pulmonary edema. These are the buzzwords. Honestly, I can't see any of them except the edema. But in an OSCE, I don't know, if you can sort of see something, just say it. Just to get the marks. Yeah. Yeah, so next question. Palpitations, collapse of CPP, 20-year-old guy, so it's really young. That's a buzzword. Shows left ventricular hypertrophy and stenosis of the aortic valve. So because the guy's so young and suddenly collapsed from exercise, it's most likely Hockham, which is unfortunate, yeah. 24-year-old. 24-year-old guy with ERT, palpitations and dyspnea. Clinical signs of cardiac failure, complete recovery over. Oh yeah, so because he's got history of ERT in the past, he's got complete recovery over several weeks with conservative management. So he didn't do anything. He's probably just, you know, go home, drink fluids, whatever. So it's most likely viral. Yeah, so ECG.
I explained them and only tell us now.
Yeah, so look at lead 1. You got ST elevation there. But don't like answer the question just yet. So you look at lead 2, ST elevation. Look at this lead, there's ST elevation, ST elevation, ST elevation. There's ST elevation everywhere. So it's not actually a myocardial infarction, so it's pericarditis. And it kind of looks like a saddle shape. Yeah, sure. Voltages in all leads are significantly reduced. So when the voltage is reduced, you're thinking that there's a lot of fluid around the heart, so you can't actually get to it as well. So most likely tamponade. ST elevation in V1 to 4, so that's just around here. So that's the anterior myocardial infarction. So a 25-year-old who's collapsed while dancing at a nightclub. She's got menorrhagia. So the reason why they've included, the reason why they've included menorrhagia is because they want you to think that she's got anemia. And she also looks pale as well, so anemia. So because of that, it's not actually a pathological murmur, it's just a flow murmur. So if we go back. Sorry, I didn't go through it. Yeah. So flow murmur. So it's a mid-systolic, anemic young female. So that's buzzword for that. Oh shit. Yeah, whatever. Okay. So ejection systolic murmur, radius carotids, AS. Tricuspid. So tricuspid is basically you get really severe right heart failure. So you've got the JVP elevated, pansystolic murmur, pitting edema, tricuspid. So the guy sleeps on 3 pillows, shortness of breath. Oh, sorry, you don't need to read anything actually. Rheumatic fever. So, so this question is 60-year-old man, 4 weeks lethargy, loss of weight, night sweats, pallor, mitral valve incompetence, so mitral regurg, mild splenomegaly. It's got a bit of anemia, white cell count is increased, platelets are reduced a little bit. It's got some renal failure. So this question, I personally think it's infective endocarditis, just because infective endocarditis, you can get night sweats, you get that like murmur, you get the pallor, you get the splenomegaly. Some other people thought it was multiple myeloma just because of all the systemic features and the renal failure. But I think you would get reduced white cell count with multiple myeloma. 65-year-old guy, he's got unequal pulses, early diastolic murmur. So the early diastolic murmur, so I think that's getting at like aortic regurgitation. And if the aortic dissection is close to the aortic valve, you get that regurg murmur. So aortic dissection. 7-year-old guy, so yeah, really rushing through it. So it's got COPD, right ventricular hypertrophy. So it's got long-term respiratory conditions. So that obviously increases that pulmonary blood pressure. So pulmonary hypertension. 7-year-old woman with high blood pressure, loss of weight, 1 year cold fingers, positive ANA, 2 normal cycles. Actually, I don't know what this is. All right, it's asking for management. All right, sorry, life lessons. So read the question. So most appropriate management. It's just a high blood pressure station. Sorry. So it's she's got high blood pressure. So basically, they're asking you what's the medication for it. So we're just looking for contraindications to ACE inhibitor, which is that dry cough. And because she doesn't have anything, it's 95% of the time it's ACE inhibitor. Just some more ECGs. I'll quickly go through it. So we look at V2 ST elevation, V3 ST elevation, 4-5 ST elevation. So it's a anterior lateral infarct, I think, AMI. Yeah. Oh no, sorry, it's not. So these are just some of the, I guess, if you don't want to learn the lead locations, this is just memorize this if you want to know the location. Oh crap. We'll just skip to, oh yes, right bundle branch. Okay, so the reason why it's right bundle branch block is because when you look at the QRS, so bundle branch block is when like the electrical conductivity, it's not getting to the right bundle branch. You guys know where the right bundle branch is, right? So it goes towards the right side of the heart. Because it's not getting there, it actually takes longer for, so the heart actually kind of gets the electrical signal around the left side and then back around the right side. So because of that, it takes longer for ventricular depolarization. So that's the pathophys of it. So because it takes longer, you get that wide QRS complex. So obviously this is a lot more than 3 squares. So from here to here. So that's, I guess, a right, or you suspect there's something going wrong there. And to figure out whether it's right or not, the way I like to think about it is that this is not very accurate, but it's just the way I use. So V1 is more on the right side of the heart than V6. And if it's positive, so if it's pointing upwards, then it's the right side of the heart. So it's right bundle branch block. It's not very accurate, so don't tell your cardiologist that, but it's just good for exams. So wide QRS in V1 is like increased. I don't know, the William Marrow, I don't like it because I never see the W and M. So yeah, there's just a bit more about it. You can read it in your own time. So this one, when you look at the QRS, it's very wide again. But when you look here, the V1 is quite negative and V6 is quite positive. So V6 is more on the left side of the heart. So I think it's a left bundle branch block. It's not very accurate, but it works. So this is just a summary of the bundle branch blocks. You probably won't get it, but if they're mean, they'll give it to you. Yeah, sorry, I can't be bothered going. It's not enough time. So this is ventricular pacing. So as you can see, this looks really weird. It's literally just a vertical line. So that's just the pacemaker pacing for the heart. So this one, when you look at it, there's a PR interval is prolonged. So it's 1st degree heart block because it's quite constant, quite regular. This is 3rd degree, so I've put the arrows there, so it's all sort of not in sync at all. And this ventricular standstill where you're just not getting anything. Yes, yeah, we've already been through this. Yeah, pericardial effusion. So as you can see, the amplitude is really low. So you would suspect there's so it's either tamponade or effusion, so there's a lot of fluid around it. And you also get electrical alternans. So that's when it's one strong one. So the heart can beat one strong one, and then the next beat, it can't fill as much. So it's a bit lower, and then it can fill again, and then it beats more. So that's why it's like alternating high and low. Yeah, so this is left ventricular hypertrophy. So similar to before, so V1 is more on the right, and as you can see, it's really negative. V6 is on the left, and it's really positive. So I think there's something wrong with the ventricles because the QRS is a really high amplitude, so it's probably hypertrophy. To figure out which side it is, I just think that V6, because it's the left side and it's positive, it's on the left side. Atrial flutter, so you've got that sawtooth pattern, pretty classic. Yeah, I think it's AFib. Yeah, AFib. So there's no P wave, it's irregular. Yeah, so Wolf Parkinson White. So when you look at the PR, for some reason you can see that it's like slanting upwards. So that's the delta wave. The pathophys of it is that you get like a re-entry circuit, like electrical signal that sort of bypasses the AV node. So because it bypasses the AV node, you don't get that proper AV node block, that like AV node pause. And because of that, it starts the QRS depolarization a bit earlier than normal, which is why you get that. Like, yeah. So VTAC is pretty obvious. Please don't miss this. I think they'll fail you if you miss this. Yeah, torsades, VFib. Yeah, don't miss any of these, please. Yeah, okay, so just OSCE advice. So this is the possible stations that I think they can test. So cardio exam, we've had cardio exam 3 years in a row. We'll probably get it again this year. I don't know. Please recognize AS, MR. Please know all the green conditions. So AFib, AMI, what else is there? Yeah, you guys know the green conditions. You can also get a peripheral vascular exam, so please know that as well. It's a separate exam to the cardio exam. History, you can get like a guy who presents shortness of breath, chest pain, palpitations or syncope. These are a bit less likely, but you can get it. They might also get like ankle swelling, and it might be heart failure, but it's most likely shortness of breath or chest pain. Like we're almost guaranteed one of these. ECG, so last year we had shortness of breath for asthma, and then chest pain for the cardio exam. You'll probably get ECG interpretation, definitely management and counseling for one of them. We also had a really weird station last year. It was cardiovascular and metabolic risk assessment. I'll talk a bit about that later. And then please know your management. Never forget SNAP-W. Like, just always say it no matter what. Please learn all your green conditions really well. I think usually for OSCE it's a green condition, but if faculty is mean, they can put a blue condition if they want. But yeah, this is my summary of the pre-clin cardio exam, and this is the year 3 cardio exam from the Clin Skills book. Neither of them are too accurate. I think it's a combination of both. So generally they get you to do a focused cardiovascular examination based on the presentation. So I think it's kind of up to your judgment. So always do general appearance. So like just checking like whether they look well, you know. For these sorts of things, when Nadita taught this, like, I don't know, it's not very useful. Sorry, Nadita. But like marker and syndrome, I don't know, you don't really need it. Like no one in the hospital looks for that. Just look for like dyspnea, fatigue, cachexia, the important things. I think it's important to go to the hands if you suspect like an infective endocarditis, if you're looking for heart failure, because they'll get reduced capillary return and peripheral cyanosis. So I recommend doing the hands. The year 3 one doesn't have hands on it. I think quickly go through it. And definitely please do vital signs for cardio exam. Please do pulse and blood pressure. For eyes, I think do anemia. I don't know, up to your own judgment, guys. They never release OSCE feedback, so we don't know what they want. Like you probably don't need Argo Robertson. Definitely don't do that. But I think do the mouth. So do central cyanosis, dentition. It's just nice to do central cyanosis. They don't have it in the 3rd year one. I don't know. I feel like the 3rd year one is really summarized. It's probably not the best one. Please do the neck. Do JVP for every cardio exam. Please do JVP. Do carotids, and then try to get to the chest as soon as possible. So for peripheries, do it in like 1 minute, 1 to 2 minutes, please. My tutor always roasted me for taking 4 minutes to get to the chest. So please get to the chest, just the general inspection, redness, rashes, respiratory effort, check for pacemakers, check for any like surgery scars. I think last year in our abdo exam, they literally drew a line. So it was like a line. And then I asked the examiner, I was like, what's that meant to be? He was like, that's a scar. So I was like, yeah, there's a scar there. Yeah, so please actually look for stuff. Don't assume everything's normal. Yeah, so for the chest, palpate the apex beat, check the thrills. This will most likely be normal on the sim patient, all of these, so you can just rattle it off. But please pretend like you're actually listening. For auscultation, I like to start at the mitral valve, so I use the bell, use the diaphragm, tricuspid, pulmonary, aortic. And then I like to remember that it's E-I-I-E, so expiration, inspiration, inspiration, expiration. And then the pulmonary aortic, you lean forward, and then the mitral, you get them to roll onto their left. Yes, that's the central cardiovascular exam. I don't know, faculty is really vague on what you do. Please mention, so in 3rd year, they want you to listen to the lungs as well for a cardio exam. So please listen to the lungs. You can also mention you'll feel like the liver, for like tricuspid regurg or something. Just mention everything. I don't know. OSCEs are so weird. So for PVD, it's sort of a separate exam in year 3, but I think if they want you to do a focused cardio OSCE, please look for putting edema at least if you have time, and then mention ideally I'd also like to do a peripheral vascular examination. So this is the Pvd exam from the year 3 Clin Skills book. So it's literally, I don't know, they want you to do I don't know, because in Tally O'Connor they want you to do upper limb as well, but in this one they just want you to do lower limb. So I guess just use your judgment. Like, do you have time? If you don't have time, just mention that you'd also check for things in the upper limb and things like that. So last year we basically had a lower limb diabetes exam, which is basically a PVD exam. So we had to do all of these things. So look, feel, special tests like they don't have it here. But I think mention Berger's test. Mention that you like to do an ankle brachial index as well. just like to flex on the examiners, yeah, just mention it. Yeah, so I'll briefly go through it. So the structure of the exam, so the structure of the exam, so on the piece of paper, they'll actually tell you exactly the amount of time for each task. So for example, they'll be like, do a cardio exam, 6 minutes, questions, 2 minutes, for like asthma history, I don't know, 4 or 5 minutes, and then management 3 minutes, things like that, which is really nice. I'm not sure if they expect you to time yourself this year, but for 4th years, they expect us, oh yeah. So please bring a stopwatch. Please bring a stopwatch. It's really useful. So I'll briefly go through it. So our cardiovascular exam was like some guy came in with a symptom, I think chest pain, and they want you to do a focused cardiovascular exam. So please remember to put the bed up at 45 degrees. They might put it flat. I think for ours it was flat actually. So please put it up. They're just, you know, trying to trick you. Please stand on the right side of the patient at all times, and then go through your exam. Afterwards, they made me listen to like the murmur, and I was literally like, what the hell is this? But it's most likely a systolic murmur. So it's either ejection systolic or pansystolic. Some of the sites actually gave the location. Some sites didn't give the location, which is really, really bad, right? So please just ask them for the location if they don't give it to you. Yeah. So it's most likely MR or AS, learn them really well. And other questions were like, how do you differentiate them? Yeah. So you mentioned like HOCM, you mentioned MVP, so the mitral valve relapse. You can mention tricuspid regurg, which also, yeah, tricuspid regurg can mimic mitral regurg, things like that. So for cardiovascular risk assessment counseling, this is a really weird station. A lot of people actually failed this station. So this was like one of my first stations at 7 a.m. in the morning, and the guy was reading off a piece of paper. It was so weird. So it was pretty much a guy who came in for just a health checkup, and then you get investigation results, and they want you to go through the investigation results, interpret it, and then explain your management and the diagnosis to the patient. So the guy pretty much had every single cardiovascular risk factor. So he's obese, he's male, he's elderly. He smoked, his exercise was crap, his diet was pretty bad, he had high blood pressure, the cholesterol readings were really bad, so low HDLs, high LDLs, high triglycerides. They also gave BSL, so he had like 11 or something for fasting blood sugar, so he's probably got diabetes as well. So he pretty much has every single risk factor. So what they expected you to do is tell him that he's got a really high risk of cardiovascular disease, basically. And you need to go through the management. So lifestyle, SNAP-W, go through all of that in a lot of detail. They love the lifestyle factors. For high blood pressure, you start them on ACE, for statins, for cholesterol, start them on statins. For blood sugar, you can start them on metformin, or if it's really bad, like insulin, not insulin, like sulfonylureas and things like that. So literally just go through all of that, and then go through the complications. So you can get a heart attack, you can get like stroke, everything, all the risk factors for those diseases. So yeah, that's a really weird station because the structure was quite different to your usual auscultation. Basic life support. So you literally walk in as a dummy, and they want you to go through everything. So you go through the doctor's ABC, and then they want you to check. They want you to do the Goodell. They want you to show them how you would measure the Goodell. So it's from it's from the angle of the jaw to the angle of the mouth. And then they ask you how you put it in. So you put it in like that, and then you turn it around 180 degrees. And then you put on the oxygen mask as well. And they want to see you do that head chin, what is it? Chin tip, head lift, chin tip, I don't know. Just do that. And then, sorry, I forgot all my bits. And then you do the oxygen mask, and they're actually looking for chest rise. So please get a secure, just get that chest rise, please. And then the questions they had afterwards was, so they gave you an ECG and they were like, what's this? And you're like, that's ventricular fibrillation. And then they're like, what are the causes of it? They were like, what's your management? So your management is literally a defib. So that's your management. And then they asked, what are the reversible causes of defib, of cardiac arrest? And then you go through the 4 H's and 4 T's, and that was that station. The rest of it is they were really quite nice in our year. Oh crap, sorry, that's 2018. Sorry, I was really cooked last night. Sorry. It was like 2 a.m. Okay. So, Yeah, so, oh crap, sorry,
No, all good, all good.
Yeah, so they were really nice to us for our OSCEs. They were literally all green conditions, and there was like one from each state, one from each system. They didn't give us any like weird opt-down or derm or anything like that. Hopefully they won't give it to you guys either. It was really stock standard like OSCE stations. So we had diabetes, asthma, migraine, small bowel obstruction, prostate cancer. Well, this one's a bit difficult, but it was still all right. Rheumatological hand exam and jaundice, which is hepatitis. So I'll briefly go through how I do the cardiac history. So in third year, they really want to see you rule in and rule out conditions, especially red flags and common conditions. So, and they also really want to see that you're checking for risk factors. So please go through all of these. Just go through them for cardiac histories. If you ever forget what you're doing, like in terms of cluster questions, just go back to the systems review. So this is my systems review. Yeah, I don't know, you guys don't like it. So it's just CDOPS, FAPI, chest pain. I don't know, I like it because it's a really good order. So it goes through chest pain, dyspnea, orthopnea, heart failure, AMI, heart failure, palpitations. Yeah, it's just really good. So if you ever get stuck, just go back to it. Like, just make sure you try to cover it. So reading time, in my opinion, reading time is the most important time in OSCE. So literally write down everything in reading time, because once you're in the station, you're literally too stressed to think about other stuff. You just kind of just go through everything on your sheet of paper. So during my reading time, I like to come up with a list of differentials. So if it's chest pain, my main method is going through systems. So I draw like an array like cardio, resp, and then what are some of the differentials, what are some of the questions to ask. Actually, you should probably know the questions to ask by now. And the risk factors, but just getting those differentials down. Writing past history, family history, drug history, social history, investigations, management, just having all those headings down, just so you don't forget anything. Because it's really easy to forget stuff when you're under stress and pressure. Yeah, so Michelle has just probably gone through all this, but cluster questions, please. They love that in third year. Yeah, so this is kind of my structure. Yeah, oh yeah, WWQPAA, depending on what the presentation is. You can't do it very. Yeah, this is a bit of a summary of chest pain. You can go through it in your own time. And this is another, I also stole this from someone else. This is also another nice way of just learning chest pain. In the actual OSCE, realistically, you'd only be able to rule in or rule out just a couple of conditions. So just the main ones you think are important. So like you don't need to rule out GORD if you really don't think it's GORD and it's a chest pain and it's probably like a heart attack. Like don't worry about GORD, things like that. Yeah, this is for shortness of breath that you go through in your own time. Yeah, I honestly think you'll get one of these, so please learn it really well. Yeah, just some more advice for year 3 exam. So paper 1, our paper 1 was pretty tough last year. So I walked in expecting to get like an easy 80–90% just because we had all the past papers released to us. But they literally didn't repeat a single question. So that was such a waste of time doing past papers. Yeah, so I don't know, last year they had some really weird questions. So there was a lot of R2, R3, most appropriate initial investigation / management question. So like based on the EMQs we did and past papers, it's all like diagnosis, right? So that's what I thought it would be. But it's literally all investigation and management. And they literally give you like 20 investigations and management and ask you for the most appropriate initial one. So it's like, what does that even mean? Is it for diagnosing or just what you would do first? So it's really weird. So please practice like investigations and management questions. Still do the past papers. It's good to see what sort of structure they have. But please don't spend like hours trying to figure out the answer to like contentious questions. They probably won't even repeat those questions anyway. Yeah, so paper 1, I don't know, it was really weird last year. Paper 2 is quite nice. I think the standard deviation for that is like this much. So if you lose 1 mark, it's like 100 people. So yeah, I don't know. The reason for that is because there's 36 pathology questions, and I think the median was 33 out of 36, because they literally repeat every single, you know those quizzes you guys have online? Yeah, they just repeat all of those. So just memorize all of those. Go through all of them, memorize them. Hopefully they don't change that for your year. They might. And just for OSCEs, please practice a lot. Please practice, especially reading time. And just practice, I guess, communicating with someone, and just practice all your examinations. I think practice is really important because when you're stressed, you you want it to just be muscle memory, especially for examinations. Reading time is super important. Write down everything you can think of during reading time. You'll be really stressed inside. It does go by really quickly when you're doing the real OSCEs, and you will be like crapping yourself before the OSCEs, especially during sequestering. So hopefully you don't have sequestering before your OSCE. Yeah, don't stress too much. I'm sure you guys will all be fine. I'm sure you'll all do really well. Yeah, just some general advice for Year 3 and Year 4. After your exams are finished, please don't throw away your Year 3 knowledge, like for pre-clin. It's really useful in 4th year still. Like I still need to learn this stuff for GP and for bio, and that's worth like 40% of, well, it's like we learn about 30% of Year 4, so please still remember it. For placements, I hope you guys all got the placements you want. If you did get forced rural or to Frankston, please don't be like, don't go in with a negative mindset, because if you go in with a negative mindset, you'll just hate everything there. Please go in with like a positive mindset and you'll really take a lot out of it. Personally, I was at Peninsula this year and I really loved it. It was a really good experience. So I'm really sure you'll enjoy your placement wherever you are. Yeah, so if anyone who's at Frankston this year has any questions, or at for next year has any questions, please feel free to send me a message. Yeah, so thank you guys for listening. If you have any questions, please feel free to send me a message, and best of luck for all your exams. Thank you guys.
Thanks, Will.
Yeah, all good.
Are those post slides?
Yeah, I'll do some editing and I'll check up.
Okay, cool.
What's the next lecture? Oh, it's morning tea.
Yeah, we've got a morning tea break-ish thing. And then after that, it's I don't know what she is.
Oh, she's like Asian with glasses.
Okay.
Oh, she might not be wearing glasses actually. How are you going?
Not too bad.
It's okay, I'll start at 10:30.
Oh, okay.
I think
It's
everyone
10:30.
is tired.
I can call them back. It's just I need to set up the recording because I don't know if it was working just beforehand. So give me a couple minutes. Do you remember how to do the YouTube? Because fucking Zoom is working.
I think they got rid of Google Hang.
Did they?
They discontinued it after September, I think.
Wait, Google discontinued. You're shitting me.
I think give Flow a call.
Oh,
Yes.
really?
Give Flow a call. Do you have a number?
No, I'll figure it out. I do have a number.
number. She'll definitely know how to do this. Sorry, I actually.
Does this do present to you?
Oh, we got 8. Dude, you have no idea.
Struggles. I saw the post and I was like, oh fuck, okay, here we go.
Thanks for coming. All right, I think they're sitting up there like a hits and shit.
How you going? Can you help?
I'm good. All right, so this.
Can you turn on the AC?
Okay, I'll try and get that sorted as well. Give me 2 seconds. I'll do that after I get the slides done. All right, that should be good. And then.
So this one doesn't get recorded.
No, this one gets recorded. That one, yeah, that one doesn't.
So how close do I need to stand?
Oh no, you can just talk normally. This will pick up all the. This is currently picking up the audio pretty well.
Okay.
Yeah, so you'll be fine. Yeah, you'll be fine in that regard. Alright. That should be all good now. Yep. So we'll just get everyone back in. Yeah, I'll go check. Go on. Thank you. Ready, so we can probably start.
Okay. Hey guys. Hello. Thank you. Right. Okay, hi, I'm Serafina. I'm one of the phobias. I'm placed in Gibson at the moment. So I might have met some of you before. Hello. Yeah. So I'm just going to go through respiratory. So the things that I'll be covering will mostly respiratory is the smallest part of specialty 1, as I guess I call the cardio resp GI block. And if you look at the distribution of it, it's compared to cardio and GI, it's very little. Like there's a bit from infectious diseases, which is going to be pneumonia. There's a little bit on maybe the perioperative care, which is like, oh, maybe you need to give CPAP to an OSA person. And then there's like 11 marks on respiratory. So if you guys don't feel confident with the buzzwords after the revision lectures series of this weekend, I found that using these 2 books were really good because they had little summary tables at the end that you could read. And they went through the explanations of the questions. Yeah. So the conditions in respiratory were R1, R2, R3. And really, in terms of third-year knowledge, as long as you have 3 cluster questions that you can ask, you can pretty much be okay in the OSCE. Like if you can think of 3 cluster questions for, especially the R2 and R3, like bronchiectasis, like did you have infections growing up? Do you have cystic fibrosis or something like that? If it's like IPF, you can ask specific cluster questions that I'll go through. Then you won't be too worried about differentials for an OSCE. You'll be pretty much set because it's only 8 minutes. You only have maybe 5-6 minutes on the history. So you just need to show you're thinking about it. And then for R1, you should know it fairly well. So in terms of respiratory as a system, I'll be going through the history of presenting complaints. Just stop me if it's boring and you guys know it already. The investigations, especially pulmonary function testing and spirometry, because those are quite accessible in multiple choice questions. And chest x-rays, I'll go through briefly. In terms of actual detailed management, I'll only really go through the COPD, asthma, lung cancer, and TB pneumonia part of it. And then I have some great slides for your PAP exam. So these are the possible presentations. Like if you guys have the summary guide, on the side of where they put the R1, R2, R3, there's like presenting complaints. And if you think about it, that means they can only ask you to ask systems questions based on those presenting complaints. So when you take a history, just general OSCE knowledge is you get the diagnosis plus 2 clusters. You get the risk factors for your top differential. So if you're thinking lung cancer, you ask them if they're a smoker or something like that. And then complications, like if they look blue in front of you, they're out of breath, they're about to fall over, you need to ask that relatively early on so that you can figure out if it's going to be an emergency type station. Right. And then that's just rules of thumb. These are all the things that, the different permutations of a respiratory history. So all rest histories, you want to see how good they're breathing, how it's affecting their quality of life, like can they still dress, cope, eat, shower themselves. You want to ask about the risk factors. So you ask them about allergies and atopy. And then you ask them about their occupational history, which is critical in a respiratory OSCE. You don't have to ask them for most other systems, but respiratory, you need to know like op health history. In terms of other things you can think about, you can also ask about maybe the ethnicity. If you're thinking TB, you can ask a specific trigger history. If you're thinking atopy, allergies, you can ask them about their infective, inflammatory, malignant stuff. Chest pain, just divide into pleuritic, non-pleuritic. In terms of managing chest pain, Will's gone through it quite well, actually. So just give them oxygen remove triggers and manage what's their underlying issue. How do I get rid of this thing? Yep. So other than that, these are the ways that you can try and delineate what you're asking. So if you're thinking PE, start asking them about palpitations and cough. If you're thinking pneumonia, you ask them about their sputum, infective history, where they live. Are they a student that lives in the halls or something and then they end up having Legionella or Mycoplasma pneumonia, something like that. And then pleuritic chest pain is a very different type of differential from your non-pleuritic chest pain. Shortness of breath, I think Will mentioned something about NYHA class. So it's like, how far do you walk, etc. That's actually used for heart failure. So don't use it to describe shortness of breath, but you can use the same kind of questions. It's just not NYHA class. So what you want to know from taking the shortness of breath history is whether they need to be put on oxygen and whether they need the ICU. In terms of cough, it's not much to say about cough history, just like what sort of cough is it, what causes it, and you want to know if there's any red flags. So infective, inflammatory, malignant, think of 2 questions, ask them, it's either yes or no, and then move on from there. And then that's about everything for the histories. Then investigating respiratory, in third year, all you have to do is, you don't have to justify yourself, you just say it as fast as you can. So every respiratory, you should be doing, if it's at all serious at all, you should consider doing chest x-ray, pulmonary function testing, peak flow management. These are like normally things. And then if there's any kind of threat to the person's life, you do an ECG. If there's any threat to the person's life, you do a LFT, UEC, CMP, VVG plus lactate because you're thinking respiratory failure. And then you can think about like weird stuff like ESR, CRP for sarcoid and things. And then in terms of other radiology, so there's something called a HRCT scan, which you can look at the lungs in great detail, and also CTPA for PE. Special test DLCOs for COPD. And then what you can take and send off to the path lab is pleural fluid plus do your lights criteria. So ask for serum LDH and protein. You go through your sputum culture. Anything that's leaking from anywhere, you just take it and send it. Okay. Pulmonary function testing is made up of a few things. So that's just what you need to know makes up a pulmonary function. Like you want to know how good their lungs are, and then you want to know what they're making, what's their response. So there's only 4 real patterns that they're going to give you. I shouldn't put ILD, it should be restrictive, but ILD is the easiest way to think about it. This table should be fairly familiar. So you want to know how big their lungs are, how good their lungs are at breathing air out, and how that compares to each other. So in asthma and COPD, their lungs are usually fairly normal, but they have a narrow airway, so not much is coming out. So the FEV1 is going to be low. So that's going to, the FEV1, FVC will be low. And then you differentiate that by doing you give them salbutamol or Ventolin, and that will help someone with asthma. And then if you're thinking it might be a restrictive pattern, they're going to have tiny lungs, and they'll have a normal amount of airway ability because restrictive things are affecting the lung parenchyma itself, not the airway. Yeah. So that's just another way to think about it. And what they really like to hear about is the definition of asthma is improving by 200 mils and by 12%. So if they give you 2 pulmonary function tests and one has improvement, but just a little bit of improvement, but one is like a lot of improvement when you give them salbutamol, pick the one with a lot of improvement. Because with COPD, you can get some reactivity, but it's not enough. So yeah, someone just call out what this is. So, oh, actually, okay, so what we look at is the ratio. So it's under 70. It's 68, which is pretty normal. And then you got 71, which is pretty normal, and there's not much change. But then because it's below 70 and there's a percentage of change in the FEV1, it's an obstructive picture. Like, so the point here is that the 200 mil and the 12% is the FEV1, is the one that you're looking at, not your FV1 FVC, which is a trap that I fell into many times. And then this one's a completely normal one. So you just need to really know how to read pre and post. And okay. Lung volumes, possible question. They could ask you to label it. I think last year, in our middle of the year formative one, we got asked to label it, and yeah, just know what form. Okay, chest X-ray. So in third year OSCE, you guys could probably fill up 5 minutes to 6 minutes with history taking. But yeah, my diagram of a chest is not very good. But you guys could probably fill up 6 minutes of taking respiratory history without any issues. You could probably say what investigations you want without any issues. And then they'll probably give you a bunch of chest X-rays. So you really need to know how to report it succinctly within 1 minute. And the way that you do it is, if you can see something, call it. So if it looks like lobar consolidation, and you just took a history from a person that has like cough and fever and everything, it's probably pneumonia. So you say like, this is a chest X-ray that is consistent with the findings with the history of a pneumonia. On the chest X-ray, signs that I see to back it up are unilateral opacification in the upper lobe or something like that. You just follow that. And then after that, you cursorily glance at the rest of it. So you look at the airway, the borders, the heart, the angles, and then look for any rib fractures. So on the post slides, if you unhide everything and then you go into presenter, like PowerPoint mode, you can actually do like sort of a test yourself 1 minute OSCE thing, because I put up a whole bunch of chest X-rays to look at. There's only a few possible ways that a chest X-ray can be shown to you. It's either unilateral opacification, probably pneumonia, but you can further describe the unilateral opacification as reticular, which is fluffy, and interstitial, which is lines. And then whether it stops at the fissures. If it stops at the fissures, that means it's kept in one lobe. If it's 2 or 3 or it's all over the lung, then it's either outside the lung or it's involving the whole lung, which is worse. And then that's what it'll look like on chest X-ray. And you can describe it like this. So you'll probably get something like this, and you'll have like 1 minute to describe it and 1 minute to say what management or investigations you want. And then if it's unilateral but solid, think of 3 things it could be. Cool. I'm just going to imagine someone's thought about it. And then this is what it'll look like. It's also described as a wipeout lung. And you can describe it like this. So frontal plane chest X-ray, salient abnormality, right lung's completely gone. The trachea is deviated. This is important because the direction of the trachea being deviated can change a differential of a wipeout lung. And then you want to see if it's having any mass effect on the rest of the lung. So yeah, if it's moving the trachea, that means they might have some respiratory distress. And if it's being pushed away, that means there's fluid or mass or something there. If it's being pulled towards it, think of it like scar tissue, it's being sucked towards it. So it could be fibrosis, it could be fibrosis. And if it's outside the lung, it's like mesothelioma. If the trachea is completely normal, it's mesothelioma because it's outside the lung, it's not doing anything to the trachea. And then the heart being deviated is more for complications. And then in terms of bilateral opacification, you really want to know if it's interstitial or reticular and whether it's the whole lung or the bottom of the lung. And then coin lesion, which is probably going to show up in your path exam as one question. Possible differentials for a coin lesion. And then bilateral hilar lymphadenopathy is just infectious, inflammatory, and malignant. And pretty much it's almost always either sarcoid or TB. Yay. Chest imaging, this one's not too important. You just need to know that HRCTs exist and you use them for fibrosis. CTPAs exist and you use them for PEs in non-pregnant women. Aye. And if you see a spiculated lesion, that is lung cancer. Next. This is what it can look like on HRCT. So HRCTs are used for your R2 conditions. Almost everything in R2 you can do a HRCT on. So if you see bronchiectasis, you do a HRCT. If you think that it's fibrosis, you do a HRCT. You think it's sarcoid, you do a HRCT. Okay, generic respiratory care when you want your last minute of going, okay, now this patient has COPD, so I'm going to give them XYZ. You're going to say, okay, lifestyle, stop smoking. Stop doing whatever is making you worse. So if you're a farmer and you have like hypersensitivity pneumonitis, stop being a farmer. That's not going to happen. And then you vaccinate them because they have an illness, they have an underlying issue. You're just going to try and, you're going to try and stop them from getting more respiratory infections that will probably destroy their lungs. And then non-farm, so lifestyle, non-farm, farm, and then severe management, which is like your ICU, ED stuff. You give them rehab and chest physio. You give them farm, which is Ventolin, preventers, steroids, antibiotics, and then severe is like weird stuff. So I put a bunch of these out as like the pre-slides reading in case anyone read it. What you can do is that you can treat this like a bit of like a, if anyone did it, it's a bit like an OSCE type thing where if you took a history and this is what you got, you have to think about what sort of condition it was. These are all lung cancers. So you guys know how to figure out which type of lung cancer it is from the history? Like any clear ideas? I think someone said something like exposure history. Yay. So what you look for is their ethnicity or exposure, their paraneoplastic syndromes, which are mega rare in real life, but everywhere in path exams. And then you look for the similar type of complications. So the first one's adenocarcinoma, because she's Asian, and she's got HPLA, and she's never smoked. Differentials are tuberculosis, especially because she's Asian. In terms of the other one, so you're thinking sudden shortness of breath with like, so you're thinking it could be a PE, which is a hypercoagulable state. You're seeing weight loss, systemic symptoms. He had renal calculi, so he's got stones. And then he's got a cavitating lesion near the right bronchus, which is like bronchogenic adenocarcinoma in some questions. And spiculated lesion. So it's definitely cancer and it's probably squamous cell. In terms of small cell lung cancer, it's the one with many, many, many paraneoplastic syndromes. So if you're seeing things that are all over the place, they're a smoker and they have a whole bunch of weird things that would never show up unless you had something lung cancery or malignant, something abnormal, then it's probably small cell. So what you want to do in an OSCE is you want to ask 3 history of presenting complaints to figure out if it's lung cancer. So those 3. And then 3 risk factors: smoking, cancer history, occupational history, 3 complication questions. So this is when you kind of show off your paraneoplastic syndrome knowledge and say, oh, do you have any bone pain? Are you confused? Do you have Horner syndrome? Don't ask them if they have Horner syndrome, ask them if they have noticed eye changes. And then the implications is that you have to stage it and grade it. So find it, tissue. This is like your path style thing. And summary slide. But remember, most lung cancers are from bowel, breast, and kidney. They really like to go to the lungs, and this is called a cannonball lung. So if you see this in an OSCE, it's a metastatic cancer. So the primary is not the lung cancer. This one, what scenario, what condition is this most likely? The first one. Someone yell it out. Okay, so he's Russian. He's got progressive shortness of breath. He was a ship worker, and it was ages ago, this exposure. Okay, between asbestosis and mesothelioma, which one does he have? Yeah, because the next one's mesothelioma. But yeah, this is how you want to figure it out, because asbestos plaques and asbestosis are different, and mesothelioma is different from asbestosis. So asbestos plaques is just a bunch of plaques on your lungs. Asbestosis involves the lung parenchyma, especially of the lower zones. And then mesothelioma it became cancer, and it happens like 20 or 40 years later. So this is another summary slide. Yay. Pleural effusions are a fairly important thing to know further on down the line, but at third year level, all you need to know is it a transudate or an exudate, and how to figure out if it's a transudate or an exudate. So if it's a transudate, that means it's more of like, remember like freaking first and second year lectures, Chris Wright going like, oh, this is the osmotic pressure or something like that. If it's something to do with the heart, liver, or kidneys, it's more likely to be a problem with managing fluid. If it's a problem that's infective, inflammatory, or malignant, then it's more likely to be a problem that your lungs are actually secreting something out. It could be pus, it could be malignant cells or something. So this is just for your PAF exam. And that's also for your PAF exam. And that's also for your PAF exam. Okay, chronic obstructive airways disease is divided into asthma, bronchitis, emphysema, bronchiectasis. Apparently they're all on the same spectrum, but on the PAF exam, asthma, chocolate-laden crystals, bronchitis, mucus plugs. La, 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 la. Nice. Okay, so this one I guess you could do as like a home OSCE. I guess like managing his asthma attack. What you want to know is, have you guys heard of this mnemonic before? Like, oh shit me? Yeah. So when you see someone has a very clear asthma type presentation and is on asthma medication and has atopy, you pretty much know it's going to be an asthma attack. So what you want to know is, firstly, you resuscitate the patient before you take their history. Okay, so if they're blue, give them some oxygen before you try and talk to them. Otherwise, be like, I don't know, kill me. So you get oxygen, you aim above 92%. If it's COPD, a lot of people talk about retainers and everything like that. The most important thing is the patient doesn't die in front of you. You can wean them off the oxygen later. Salbutamol, hydrocortisone, or prednisolone, oral or IV doesn't matter. If they have an IV inside, then you give that. And then ipratropium, it's no longer theophylline, it's aminophylline, but we still say theophylline because it fits the oh shit me mnemonic. And then magnesium sulfate and escalate to ICU. So by the time that someone gets to about ipratropium, you want to be calling your consult, because in your OSCE, you're going to be a medical student or an intern. You can't actually start all these increased medications. So you'll say like, I'll call ICU, I'll call respiratory or something, depending on where you are. Oopsie. And 4x4x4, just know how to explain it. Because our OSCE last year was, dude comes in, he's being wheezy, show him how to use a puffer and take his asthma history. In terms of assessing an acute exacerbation of asthma, you just want to divide into mild, severe, or life-threatening. And the mnemonic is MOS. So mental state, are they thinking, talking to you? Oxygen, work or breathing, which is more of a Pete's thing. And sentences. If they can't talk, it's life-threatening. That's the silent chest thing. If they can't even get out 2 syllables, that's severe. And if they can talk in a few sentences or like bits and pieces, phrases, it's not horrible. If this was in case someone wanted detailed information. No. And then you might get 1 or 2 questions on where does this drug work. So SABA is to open it up, corticosteroids is to reduce the inflammation, and then LABA is to prevent the long-term changes. You never prescribe LABA without starting a steroid first in asthma. You need to know the chronic asthma algorithm fairly well, because you can get questions on it. So last year we had a question on dude with COPD has had 2 exacerbations and he's on no medications. what should you start him on? So I thought, okay, let's start him on a LAMA, right? Because he's got exacerbations, but he's got no baseline symptoms. But if you follow the ladder, it's SABA. So if in terms of asthma, you should also have the same kind of grasp of the principles. In terms of asking asthma questions, this is how you ask a 2-minute asthma history. So like, how was diagnosed? What makes it worse? Do you have an asthma action plan? And things like that. And you need to ask like how they control it, because I think this was the way they wanted us to ask it in an OSCE. And then asthma action plan, right? Okay, that's just a summary slide for asthma. Sorry, this word got cut off. Just higher risk if there's atopy. MP Sina is a 67-year-old office worker with COPD. How bad is his COPD based on this history? So we look at his FEV1, it's 50%. He's on a ipratropium, which is a SAMA, and he's also got symptoms at baseline. So you would probably think, you probably need to start him on LABA or LAMA because it's getting worse, and it's not enough with just a PRN. And then there's Jono Broncos, a 75-year-old retired cowboy. He's had 2 exacerbations. He's on no regular therapy. This is the similar sort of question that we got asked last year. Okay, Mr. Jimmers has presented with 1 week of an increasing cough. He's got a COPD exacerbation because he's got change in sputum, change in symptoms, and history of like Miss Jimmers, sorry. Yeah. So you notice the lungs are resonant to percussion. You hear with rhonchi. It's sort of like saying that it can be quite severe COPD at baseline because you're getting like bulle and like COPD-induced bronchiectasis and things. Traction bronchiectasis. So to assess the severity though, all you have to do is check their MO score, check their symptoms at baseline, and then start doing management. So at the bottom of the PowerPoint, there's a small write-up on what you should do. And then if they deteriorate on the ward, you take their VBG, and what does this show? What sort of respiratory failure is this? Type 1 or type 2? Yeah, I saw someone say type 2. So yeah, it's type 2 because this COPD, and type 2 respiratory failure is a problem of too much carbon dioxide. So you switch off the drive to your rest of the body. The respiratory support that you should use is BiPAP, not CPAP. It has in and out. And you know that this person is a retainer, so you want to, and it's not like an emergency situation, so you can do the funny saturation thing. Okay, this is how you can ask it very quickly in an OSCE. ETG COPD ladder is horrible because it is extremely messy, so I made it into a simpler ladder. You want to find out if they smoke, if they have symptoms, if they're short of breath when they're walking to get their groceries from the car or to get another pack of cigarettes. Probably need a LAMA. LAMA, not LABA, sorry. I'll have to change that. Or LABA. And then if they have more than 2 exacerbations, you can start them on prednisolone. And if they're short of breath at rest, yeah, you can start them on theophylline, advanced care directive, because you're going to palliate them soon, and home oxygen. So treatment of COPD is just these 5 things. They want you to use the COPD X plan, but it's very unwieldy for an OSCE. And that is a summary of COPD. Okay, Sue Ton is a 22-year-old female who's presented with 2 days of cough. Yay. And then otherwise well. So this generally well, and she's got an infection. What sort of bug do you think she's got? Okay, first, is it mild or moderate or severe? She's mild, I think, because she's otherwise well. Might be wrong. Might be at the bottom of it. Yeah. And then she's probably got mycoplasma because she's a student, and it's like walking pneumonia, but it most likely is strep pneumonia, so it could be one or the other, but the most, like, you have to weigh it up. So the way that you want to decide between mycoplasma and strep pneumonia is you have lobar consolidation. Mycoplasma tends to get both lungs. It's atypical pneumonia. So you go for strep pneumonia. And then he's a 58-year-old headmaster. He's described it as coughing up blood. And he's also an alcoholic, and he's got currant jelly sputum. I wonder what he is. He's got. Yeah, I heard Legionella a lot. Yep. And Corby Lim, so CORB score is what you use to grade pneumonia, is a nursing home resident. And you hear crackles across both lungs, which clear on coughing. So it's not APO. Any idea what this could be? Honestly, it's probably still strep. So yeah, ways to figure out if it's a pneumonia or not is you ask those three. You ask risk factors, sick contacts, leisure, and if they're high level care. If it's an old person, you want to figure out if they're in a nursing home. And then complications questions. Oof. Oh my God, this thing I have to put. And then the implications of having a pneumonia diagnosis. You want to treat the patient, you want to treat anyone else he's been in contact with and spreads nasty germs to, and you want to figure out if it's a notifiable disease. This is the way I think about pneumonia. Like, do I need to admit them? You do the CURB 65. And then if you don't admit them, you give them a moxie or doxy if you think it's atypical. If you think they need to be admitted, you need to figure out if they need to go to ICU. If they don't and they go up to Gen Med and get tortured by medical students, then they get Benpen and doxy. And if they go to ICU, they get Kef and Azitra. And that's just the difference between the scores. There's a lot out there. Say any of them, and they will probably give you the table, like a piece of paper with the score on it, and you just calculate it. And that's how you investigate pneumonia. So you just list it out. Cool. In terms of blood cultures, I didn't know this until I read up ETG, but you should actually take blood cultures in people being admitted to the hospital. And that's a summary. And then that's another summary. And this is a table from that EMQ book that I put up just now. Okay, yeah. And now it's all I want is buzzwords, because at this point, I guess everyone wants buzzwords. So these are the different organisms that can cause pneumonia. So in terms of important ones here to know other than your usual ones is staph tends to be a secondary infection after influenza. So they get hospitalized for influenza, they go home, they come back, they've got staph. PJPs for HIV, and they get these weird helmets on silver stain. Yay. And these are things that aren't really pneumonia, but present like pneumonia in an OSCE. So you have to think about COPD exacerbation. You have to think about abscesses, especially if they had an infection recently. And if they're CF, you call it CF center because it's none of your business. Okay, buzzword time. What's the first one? Yay. Second one. This one. Yes, Q fever. This one. Yay. You guys passed your PAP exam. Okay. Oh, yo. So this one was just like if you were at home or something and you were bored. Sorry guys, it was really buzzy, I know. Yeah, so this one is, this dude's got Marfan's. What's the management? Honestly, you want to figure out whether he does have a PE, pneumothorax or not. If he does have a pneumothorax, you want to figure out if it's like killing him now or if it's not killing him now. Primary and secondary pneumothorax. So primary, it happens spontaneously. Secondary, they have like lung disease, so like COPD or something. And then 26-year-old male, he's got hyperresonant percussion and trachea is deviated to the left. What do? Where do you stick the cannula? Yep. And what gauge do you use? Yep, very good. How do you know whether it's the right lung or the left lung?
Chest X-ray.
No. You don't x-ray them if you think it's a tension pneumothorax. You go by the trachea and where it's resonant. So if he's resonant on one side, then it's probably, and the trachea is being pushed away from it, so it's, yes. Yay. If you x-ray them, they'll probably die if it's large and clinically unstable. So you just stick the catheter, like cannula catheter, in, and then you give them an underwater CO drain, which is something you might have seen on thoracics or vascular, and you admit them. If it's a small pneumothorax, you actually don't have to do anything. You just send home with advice and review with a second chest x-ray in 2 weeks. Okay, the end. And then next one, Miss Huang is a 35-year-old woman from Southeast Asia. What does she have? Yeah. The end. How should she be managed? Oh, that one's a bit more tricky. So she's got active TB. So she needs the full right thing. The point is though, tuberculosis can sound 100% like cancer because they get loss of weight, fevers, chills, night sweats, hemoptysis. So what you want to know is their risk factors. And if they've had a TB vaccine and if they're IVDU. And then complications, you can be really smart and ask about those. The implications of having a TB station though is that they have to be immunocompromised because most people at some point have latent TB. Like 1 billion people in the world have latent TB. I think some people here have latent TB. So if you're immunocompromised, the TB then flares up. So that's why you have to screen for HIV. And whether there's any, because it's a notifiable disease, you tell the government because they need to figure out where the TB is, and you need to treat their family because you don't want their family to have TB as well. And the reason you take culture is because there's multi-drug resistant TB, which you might not be able to cure. In terms of chest x-ray, what's interesting is that primary TB is usually around the hilum. And if it's apical TB, that means the TB's had chance to spread, so it's gone up to the apex. Yay. Tuberculosis drugs are a very popular question. So I think on the post slides, there's actually a bunch of TB questions that you can do in your own free time. All I want is buzzwords. Buzzwords, sarcoid, serum ACE, young African, probably female, bilateral hilar lymphadenopathy. You take a chest x-ray, you figure out how bad it is, and then you give them steroids or not. You will never be asked to manage it yourself, I think. This one would be more of a MCQ question. IPF, old dude, probably from Scandinavia. Fine and inspiratory crackles, probably some kind of ILD. So the thing is though, for ILD, it's different from IPF. IPF is a subset of ILD that no one knows why it happens, although there's new drugs out there like pirfenidone. For ILD, what you can remember is on a chest x-ray, if you get a pattern of it, if it's upper lobe, it's usually occupational health, because you think about it, most of the things you'll get exposed to in op health would be you breathe it in, right? So it'll go up to the top of your lungs. Except asbestosis, which somehow sinks down. Don't think about it too much because then you start thinking about silicosis and why is that on the top of the lung, okay? In terms of rheum, everything is lower lobe, like RA and SLE, except for ankylosing spondylitis. HSP is hypersensitivity pneumonitis. In fourth year, it also becomes Henoch-Sörlin fibula. So hypersensitivity pneumonitis is also something a bit weird. They start off with like flu-like earthy symptoms, and then if you don't treat them 6 months or 12 years later, they start getting fibrosis. This is a mnemonic to remember it if you like mnemonics. But that's, yeah, trashy and chats. Path exam questions. And then abscess, foul-smelling sputum. Gets lots and lots of like IVD or pneumonia. And then you see this weird looking air fluid level cavitating lesion. It's an abscess, you give them benpen and metro, and if it doesn't work, you give them ceftriaxone. And then if you can't get it with IV antibiotics, then you just cut it out. And if you don't treat the abscess, it can cause an empyema because you're getting inflammation and infection fighting around it. So it's forming pus and it's trying to kill it. And it'll look like this on a CT scan. You need a CT for empyema because you can't see the 3 dimensions of it otherwise. So it's called a split pleural sign. It's outside the lung if you have a look at it. And it's usually strep. Pleural effusion, Light's criteria that I went through earlier. You don't actually see it till it's above 300 mils though. So that's pleural effusion and what you can see in regards to it. A1AT deficiency is like maybe one question on path. They've got lung disease and liver disease, and they have pan-acinar COPD. And then you just refer them to like the Alfred lung transplant unit because they probably need one. Bronchiectasis, it can either be CF or non-CF, but the point of it is they get very highly productive purulent sputum. There's just like buckets of it, and that's bronchiectasis. B for buckets. Hey. Tram tracking, signet ring size. This is how it'll look like on HRCT. And then cystic fibrosis is really a year 4 topic, unless you're at alpha and you get like stuck on it for 2 weeks, which is great. The point is that it's usually a CFTR gene mutation. It's inherited, autosomal recessive. So if you get a CF station, you might want to consider genetic testing for their kids or something as well. And then it affects a lot of things. It affects the lung, the pancreas, the bone, the gut. Just think about it as thick, sticky sputum. MDT referral, everything else. Oh, and there's something called Creon for everybody with malabsorption. You can give them like pancreatic enzymes. Cool. That's CF. And then I think this is towards the end already. Pulmonary hypertension, you class it from 1 to 4. I thought it would be covered in cardio, but I guess it was, I guess like it's also a lung condition. And the way to diagnose it is you have to get them to cath lab. You have to put a right heart catheter in them. So through the groin. And then you figure out what's the wedge pressure. And in an exam, it'll just be loud P2 because the S2 is split. A normal physiological is S2 is made up of the aortic and pulmonary valve. So if you have a problem with the pulmonary pressure, the P2 valve will be louder because it's trying to push past all that pulmonary pressure. So it becomes louder and it takes longer to happen. Okay, OSA is more of a year 4 topic as well, but you just need to know that there's something called an Epworth sleepiness score, and you measure how big the neck is, plus all their cardio risk things. Confirm it with a sleep study, and then you probably put them on CPAP. And then there's this cool thing called a UPPP, which is a uvulo-palatopharyngoplasty, where they just cut bits out of the oropharynx. Trauma is something I think they just added last year, but there's a few things that could happen in chest trauma, which is flail chest, phrenic nerve paralysis, so they get the paradoxical diaphragm thing you might remember from 2nd year or 1st year. Pulmonary contusion is like a patchy whiteout lung, so it looks like somebody punched the lung and then now it's all like you punched an apple or something. And then tracheobronchial injury is like basically the trachea went like into 2 parts. And then they get subcutaneous emphysema because now all the gas is going into the rest of their body. These are examination buzzwords. And then it all sounds really serious, like you're going to die and get lung transplants, but then 90% of it is upper respiratory tract infections. Prescribe them chicken soup. Okay, the end. And these are the references that I use. I found the last year's MUMUS lectures really, really good. Especially the 2016 ones had amazing chest x-rays, and 2018 had like a really good lecture. Cool. The end.
Nice. That was pretty speedy.
It's not a big topic. It's really not.
Yeah.